This conference will now be recorded.
Hello, good morning everyone. Now we will discuss about chronic pain management. I am Dr. Virinchi, Assistant Professor in the Department of Anesthesiology ASRAM. So what is the definition of pain? Pain is defined by the International Association of Study for Pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So this pain is always a subjective experience, and everyone learns the meaning of pain through experiences usually related to injuries in early life. As an unpleasant sensation, it becomes an emotional experience.
ఇంకా స్టార్ట్
pain causes
అవ్వలేదంట మీటింగ్
Hello? And pain causes significant stress physically and emotionally.
స్టార్ట్ అయితే అప్పుడు
What are the various descriptions for pain? It may be somatic, visceral, or neuropathic. Somatic is caused by the activation of pain receptors in either the cutaneous, like the body surface, or deeper tissues. And visceral pain is caused by activation of pain receptors from infiltration by some tumors or external compressions, stretching or extension of thoracic, abdomen, or pelvic visceral organs. And another one is neuropathic pain caused due to injury to the nervous system, due to tumors compressing nerves or spinal cord, or cancer infiltrating nerves. And can we describe the pain in terms of severity, like mild, moderate, and severe? But it does not provide correct description. But this should be used to modify acute and chronic pain indications to allow patients to understand. And coming to the acute pain and chronic pain, acute pain is short-lasting and manifesting in objective ways that can easily described and observed. Clinically, it may be associated with diaphoresis, that is sweating, and tachycardia. It can last for several days, increasing in intensity over time, that is known as subacute pain, or can occur intermittently, that is episodic or intermittent pain. And chronic pain is long-term and typically defined if it lasts for greater than 3 months. It is more subjective and not clinically characterized as acute pain, and more often it is more psychological. And this is the most torturous thing because this usually affects a person's life, changing personality, their ability to function, and then overall lifestyle. And it has psychosocial component that must be dealt with before depression becomes a part of the clinical picture. And chronic pain should be recognized as a multifactorial disease state requiring intervention at many levels. We often come across different terminology in pain. Some of the terms which you might not have well versed are some like allodynia, that is perception of an ordinarily non-noxious stimulus as pain. Without generally, if we touch a person, he will feel the pain. That is allodynia. That is non-painful stimulus we will perceive as pain. And analgesia, that is absence of pain perception at all. Anesthesia, absence of all sensations. And anesthesia dolorosa, pain occurs in an area that lacks sensation. And dysesthesia, unpleasant or abnormal sensation with or without stimulus. And hypoalgesia means less response to noxious stimulus. Hyperalgesia, increased response to noxious stimulus. And what is the physiology of pain? This may be normal or nociceptive pain that includes acute, subacute, and inflammatory pain, or abnormal or pathophysiological pain that includes neuropathic and central pain. So what is the physiology of these nociceptors? These pain receptors are three nerve endings. Those are innervated by A delta and C fibers that respond to intense, potentially damaging stimuli that exist throughout the body. It is found in the skin in the form of high threshold mechanoreceptors, polymodal receptors, and silent receptors. And what are the chemical mediators involved in the transmission of this pain? Many will be there. Some of the important are like, which you might have heard, like substance P, calcitonin, gene-related peptide, glutamate, aspartate, ATP, acetylcholine, glycine. Some will be exudatory and some will be inhibitory. And local release of prostaglandins during the nociceptive stimulus potentiate the action of bradykinin and acts as sensitizer to these nociceptors. And these are pain pathways, like we have seen A delta and C fibers from the peripheral nerve endings in the skin. Those will go to spinal cord and then from thalamus and cerebral cortex. First order neurons will be terminated in the spinal dorsal horn on the same side as the dorsal root ganglion with primary sensory neural cells are located. These are the parts of spinal cord where this pain pathway will be relayed. Like different laminas will be there for different types of pain, like for somatic nociception, mechanoreception, visceral pain, sympathetic, motor. For each and different lamina, input will be like A delta, A beta, C fibers, and subsequently they will be represented in different parts of brain, like nucleus proprius, intermediolateral column, motor, horn, like this. This will be a bit confusing. You can refer later. In the second order neurons are white dynamic range neurons. These are located in the lamina 5 of the dorsal horn of spinal cord. Where does this modulation of pain occur? Occurs at nociceptor, spinal cord, or supraspinal structures. It may either facilitate or inhibit pain. At the spinal level, modulation occurs via gate control theory. This was proposed by Melzack and Wall. This is very most important point. Described in 1960 by Ronald Melzack, he described the physiological mechanism by which psychological factors can affect the experience of pain. A neural gate can open and close, thereby modulating pain. And this gate is located in the spinal cord. And conditions that open the gate include physical conditions like extent of injury, inappropriate activity level, and emotions like anxiety, worry, tension, depression, mental conditions, focusing of pain, boredom, medications and counter stimulations like heat and massage. And these close the gate, and positive emotions, relaxation, rest, and mental conditions like intense concentration or distraction, involvement, and interest in life activity. When gate closure occurs, we will feel less pain, and when this gate opens, we will feel more pain. And then, as we have discussed previously, the peripheral nerve fibers involved in pain are A delta and C fibers. And A delta fibers are small myelinated and they transmit pain. C fibers are small unmyelinated. They transmit dull or aching pain. And hypothalamus, pons, and somatosensory cortex stimulation causes analgesia. And there are three endogenous systems in the body which inhibit the pain pathway. These are opioid system, noradrenergic system, and the serotonergic system. So what are the detrimental effects that will be caused by this acute or chronic pain on the body? The physiological responses that occur are increased catabolic demands, leading to poor wound healing, weakness, muscle breakdown, and you cannot move the limb, which is more painful. So there might be increased risk of deep venous thrombosis and pulmonary embolism, which is very detrimental. And respiratory effects, if you have some abdominal pain or chest pain, you cannot take deep respiration, leading to shallow breathing, tachypnea, cough suppression, cooling up of secretions. So increased risk of pneumonia and atelectasis. And there will be increased sodium and water retention by renal mechanism. There will be decreased J mobility. There will be tachycardia and high blood pressure. And the psychological effects will feel anxiety, depression, cannot sleep properly. And the existence of suffering means patients will have some suicidal thoughts like that. We can't tolerate this place, I want to end the life, that sort of things. And there are immunological effects of pain also that include decrease the natural killer counts and affect another lymphocytes not yet defined, but NK cells decrease leading to decreased immunity. So coming to our topic, how will you manage this chronic pain? This is not a single treatment or medication, nothing is available. This will be multimodal only. So what is that chronic pain? Chronic pain continues a month or more beyond usual recovery period for an injury or illness, or it may go on for months or years due to chronic condition. It may not be constant, but it disrupts daily life and day-to-day activities, interferes with sleeping, keeping you awake at night, interferes with daily activities, walking, and everything. And it may be nociceptive, neuropathic, or both. And psychological mechanisms play a major role. And the chronic pain is multifactorial. First of all, psychological factors like depression, anxiety, and traumatization. And there will be socioeconomic factors like cultural differences, urban, poor, gender, and spiritual factors like spiritual suffering, meaning of pain. So best approach for pain management is multidisciplinary. So what are the common causes of this chronic pain? Some episodic pain syndromes. Most often, many of us experience severe headaches like migraine, tension headache, cluster headache, and ischemic episodes like claudication, angina, sickle cell disease. And there will be visceral pain due to some renal stones, biliary, colic, irritable bowel, premenstrual syndrome, and somatic pain due to chronic disorders like gout. And most often, somatic pain syndromes will be low backache, inflammatory arthritis, neuropathies, failed surgeries, fractures of the vertebrae, bony metastasis due to carcinomas, myofascial pain syndromes. And visceral will be most often like chronic pancreatitis or abdominal cancer. And neuropathic will be complex regional pain syndromes, post-herpetic neuralgia, trigeminal neuralgia, diabetic neuropathy, phantom limb pain. And neuralgia is like extremely painful condition consisting of recurrent episodes of intense shooting or stabbing pain. And cathalgia, like severe episodes of burning pain, phantom limb pain. This is one peculiar thing where patient will feel pain in a limb that is no longer there and has no functioning of seen after below-knee or above-knee amputations. And how will you evaluate the chronic pain? First, medical evaluation we will do, like the location of pain, onset, quality, radiation, and response to previous treatments, and history of past personal, social, economic, psychological, and emotional status, and by taking plain X-rays, CT, MRI, and bone scans. Psychological evaluation will be done by clinical interview, and some questionnaires will be there, some scales for measuring the intensity and duration of pain, like the McGill pain questionnaire, which is very famous and commonly done, psychosocial pain inventory, and pain profile. And some psychometric testing devices in the Western countries, like Minnesota multiphasic pain inventory, symptom checklist, back diffusion theory, and electromyography and neuroconduction studies. These are useful for confirming diagnosis of entrapment syndromes, neural trauma, and polyneuropathies. This measurement of pain helps in quantitation of pain severity, determine the therapeutic interventions, and evaluate the efficacy of treatments. Some of the pain scales are numerical rating scale, PASS rating scale, visual analog scale, and McGill pain questionnaire. In the visual analog scale, we will put a 10 centimeter scale and draw some 6 diagrams, which is shown like this. And based on expression, we will see whether it is mild or severe pain. In numerical rating scale, numbers from 1 to 10 will be there, and we will ask the patient to tick a number where 0 is no pain or distress, and 10 is most unbearable and incapacitated. The McGill pain questionnaire consists of 3 dimensions: sensory, motivational, and cognitive. It contains 20 sets of words that are divided into 10 for sensory, 5 affective, 1 evaluative, and 4 miscellaneous. Then coming to the common conditions that cause chronic pain. Low back pain, most often low back pain is caused by muscle spasms, strains, herniated nucleus pulpus, that is intervertebral disc, degenerative disc, annular fissures, and spinal canal or phonabulous stenosis, hip osteoarthritis, ankylosing spondylitis, epidural abscess, osteomyelitis, primary cancer, or metastatic cancer. The best treatment most often is the bed rest, but shown to impede the recovery. And the current consensus says that maintenance of minimum activity and work status should be there. And if persists for beyond 4 weeks, we have to refer to multidisciplinary pain center. Spinal stenosis is the general term for congenital acquired disorders of spine. This is due to narrowing of bony frame surrounding neural structures. It can affect central spinal or lateral intervertebral foramina. It can be caused due to spondylolisthesis or osteoarthritis or degenerative disc disease. And failed back surgery is also known as post-laminectomy syndrome. Is the most difficult group of chronic pain, exhibits strong nociceptive and neuropathic characteristics. Sharp and shooting burning pain will be there. This is iatrogenic and development of fibrous scarring due to surgery. And myofascial pain syndrome, the soft tissue disorder that creates pain in tender areas within these muscle groups. The diagnosis is made on clinical trigger points. Painful area usually feels like a rope created by events like trauma or prolonged tension from poor posture. And therapeutic modalities include passive stretching, cold spray, compression massage, injection of 0.5% lidocaine at the trigger point, and botulinum toxin injection. The other most common complaint of pain is headaches, which many of us often experience regularly. It consists of several types, and majority might have experienced migraine headache, or tension headache, cluster headache, and headache due to other vascular disorders like Takayasu arthritis, stroke, venous thrombosis, and neuralgias like trigeminal neuralgia, or there is some intracranial pathology like brain tumor, CSF leak, pseudotumor cerebri, infections causing meningitis, aneurysms in the brain. And some eye disorders like glaucoma and optic neuritis cause severe headache. and allergic or bacterial sinusitis, and dental disorders, and drug-induced like caffeine and alcohol withdrawal, and some viral infections like influenza, fever, bacterial, fungal infections, and metabolic like hypoglycemia, hypoxia, hypercarbia can also cause headache. What is complex regional pain syndrome? This is a neuropathic pain that involves both upper and lower extremities. It consists of previously they used to nomenclature is like reflex sympathetic dystrophy and causalia, but now they are calling it as complex regional pain syndrome 1 and 2. One is reflex sympathetic dystrophy and 2 is causalia. The CRPS type 1 it follows minor trauma. Preceding events may be trauma, surgery, sprain, fracture, or dislocation. And you can see in the picture the difference between right and left hands, how swollen edematous and shine with the left hands. It consists of three phases: acute, dystrophic, and atrophic. In acute, there will be localized and severe pain, and extremities will be feeling warm, skin will be dry and red, but X-ray looks normal. It lasts up to 3 months. And when it enters dystrophic phase, pain will be more diffuse and throbbing, and extremity from warm it becomes cold, cyanotic, and edematous. Muscle wasting will start, skin will be sweaty, and X-ray shows osteoporosis. It lasts for 3 to 6 months. In the final phase, atrophic phase, less severe, often involves other extremities. There will be severe muscle atrophy and contractures. Skin becomes glossy and atrophic, and X-ray reveals severe osteoporosis. And duration is we cannot predict; it may last for years or so. The complex regional pain syndrome type 2, it is also known as causalia. The symptoms will be burning pain following high velocity injuries to large nerves. Pain is immediate in onset, associated with allodynia, hyperpathia, vasomotor, and pseudomotor dysfunction. Treatment for this is sympathetic blockade. Physical therapy plays major role. The cure rate is high if treatment is initiated within 1 month of symptoms and appears to decrease with time. Post-herpetic neuralgia is an intractable pain that develops as a sequelae of acute herpes zoster infection. And pain usually resolves in 3 to 4 weeks, and if it lasts longer than 4 to 6 weeks, this post-herpetic neuralgia should be suspected. In this condition, large myelinated fibers are destroyed. Typically presents with unilateral pain in the dermatomal distribution, and treatment is sympathetic blockade, antidepressants, anticonvulsants, opioids, and transcutaneous electrical nerve stimulation. And trigeminal neuralgia, which is also known as tic dolorex, it represents as a painful unilateral affliction of the face characterized with brief electric shock-like pain limited to the distribution of one or more divisions of the trigeminal nerve. It's commonly evoked by trivial stimuli, including like small things we do daily, like washing, shaving, smoking, talking, or brushing, or it may occur spontaneously also. And the pain is abrupt in onset and termination may remit for varying periods. The treatment includes carbamazepine, invasive treatment like glycerol, injection, radiofrequency ablation of the Gazarian ganglia, and microsurgical decompression of trigeminal nerve. What are the chronic pain management goals? How we manage this chronic pain? First of all, our goals are to improvements in nociception and not complete cure. There should be decrease in pain and suffering, and we should be able to do daily activities and instill hope to the person. What are the therapeutic modalities? Various modalities available. There may be pharmacological management, physical measures, psychological measures, and finally, invasive techniques. The pharmaceutical control of pain. About half of the hospitalized patients who have this chronic pain are under-medicated, and children are at particular risk of poor pain control measures. And also, we give medication like as needed or as a prescribed schedule, which may not be sufficient for majority of the people. Commonly, what are the drugs used for the chronic pain management? These are NSAIDs, cyclooxide inhibitors, opioids, antidepressants, anticonvulsants, corticosteroids, and systemic administration of local anesthetics. NSAIDs, traditional NSAIDs are effective in the treatment of mild to moderate pain, but their use is limited by potentially serious adverse effects. And ketorolac is indicated only in the management of moderately severe acute pain that requires opioid level analysis and not more than 5 days. Selective COX-2 inhibitors, celecoxib, rofecoxib, and valdecoxib. And this table shows some of the NSAIDs and the maximum daily dosage and the frequency of administration. You can see paracetamol, aspirin, diclofenac, ibuprofen, ibuprofen, indomethacin, ketorolac, naproxen. Sorry for interruption. And coming to opiates, which are most commonly used by anesthetists all over the world. These are weak opiates, intermediate strong opiates will be there like codeine, fentanyl, hydrocodone, hydromorphone, methadone, morphine. This fentanyl and all are very powerful and mostly used in the operation theatre and most commonly in the post-operative ICU settings. In this table shows some of the common opiates with half-life, duration of onset, initial dosage, and the dosing interval. And what are the principles of opioid analgesic use in the chronic pain? First, we should individualize the route, dosage, and schedule. Administer analgesics regularly if pain is present most of the day, and become familiar with the dose and time course of the several strong opiates. Give infants or children adequate opioid dose. Follow patients closely, particularly when beginning or changing analgesic regimens. And if we want to change to a new opioid or a different dose, we should use equianalytic dosing table, like morphine how much mg equal to fentanyl how much mg, like that equianalytic table we will have. And so that there won't be a difference in the clinical level of the alleviating the pain. And recognize and treat side effects. Be aware of the potential hazards of some opiates like meperidine, mixed agonists, antagonists like pentazocine. And do not use placebos to assess the nature of pain. And watch for development of tolerance. You should treat it appropriately and watch for development of physical dependence, and you should prevent withdrawal. Do not label a patient psychologically dependent as addicted if they mean physically dependent or tolerant to opiates. Be alert to the psychological side of the patient always. And what are the side effects of opiates? Constipation. And no tolerance develops to constipation. And nausea and vomiting. Tolerance occurs in 2 to 5 days. Sedation. Tolerance can occur in 2 to 3 days. Clonic jets. Usual high doses can change drug or diazepam and help in such situations. And respiratory suppression, toxic doses. Never see it if you have pain or use the drugs right away. Can produce hyperalgesia. These opiates can produce hyperalgesia in certain individuals. And what is the difference between physical versus psychological dependence? Physical dependence, tolerance, seen in 20 to 40% due to upregulation of opioid receptors to need higher dose for sustained effect. And withdrawal seen in 20 to 40%. After 2 weeks, withdrawing drug leads to adrenaline response like sweating, tachycardia, tachypnea, cramps, diarrhea, hypertension. It can be avoided by decreasing the drug 25% a day. And psychological dependence. Need to get high where drug controls overlap, compulsive uncontrolled behavior to get the drug, like they may lie, they may cheat or steal the pseudo addiction, physical dependence confused with psychological dependence, pain relief seeking, and this is not drug seeking. When right dose usually the patient functions better in life, there is opposite case true with the true addict. And to help differentiate controls the drug under the specific contract with patient, one pharmacy visits and pill counts. Co-analgesics. Definition is agents which enhance analgesic efficacy, have independent analgesic activity for specific types of pain, and relieve concurrent symptoms which exacerbate pain. What are the co-analgesics commonly used for pain? Many drugs will be available. Some of them are antidepressants, anticonvulsants, corticosteroids, neuroleptics, antihistamines, analeptics, benzodiazepines, antispasmodics, muscle relaxant, and systemic local anesthetics. And antidepressants are effective agents in the treatment of neuropathic pain. Their main action is due to blockade of presynaptic reuptake of serotonin, norepinephrine, or both. And serious side effects include anticholinergics, dry mouth, confusion, and urinary retention. Example of some antidepressants are amitriptyline, clomipramine, doxepin, fluoxetine, imipramine. And anti-epileptic drugs, these have been used for many years in the treatment of neuropathic pain, particularly trigeminal neuralgia and diabetic neuropathy. And their mechanism of action is blockage of the voltage-gated sodium channels and can suppress spontaneous neuronal discharges. Examples include phenytoin, carbamazepine, and valproic acid. And newer agents like gabapentin, which is most commonly used, most effective and well tolerated, and is used in many centers all over the world. Neuroleptics, these are antipsychotics useful in patients with marked agitation or psychotic symptoms. Examples include commonly will give serenase, that is haloperidol, fluconazine, chlorpromazine, and chlorpheniramine. and action is due to blockade of the dopaminergic receptors. And corticosteroids, glucocorticoids are essential used in pain management due to their anti-inflammatory and positive analgesic actions. They can be given topically, orally, or parenterally. Coming to the local anesthetics, it is systemic administration of local anesthetics, lignocaine infusion. This is more effective in neuropathic pain, but can be used for all pain syndromes. And with the starting doses of 0.5 to 2 milligrams per kg per hour, can be given intravenously or subcutaneously. Some studies demonstrate long-lasting pain relief even after drug has been stopped, and need to decrease opioids and starting. And lignocaine patch also will be available 12 hours on and off. You can leave for 24 hours also, but this is more expensive. And clonidine is an alpha-adrenergic agonist. Its action is by the activation of descending inhibitory pathways. It can be given by epidurally, intrathecally, or parenterally also. And the wonder drug ketamine. This ketamine is the NMDA, that is N-methyl D-aspartate receptor antagonist. It is used as anesthetic for years. And case reports show effectiveness when traditional invasive techniques fail. Starting intravenous dose 150 mg QAD, that is 0.1 to 0.2 mg per kg, with reduction of opioid achieved, or 10 to 15 mg 6 hourly, that can be increased to 10 mg dose each day. Increases by 10 mg each day. Appears to have synergistic effect when used concurrently, simultaneously with opioids. And some other adjuvant analgesics miscellaneous are pamidronate, zoledronic acid, strontium, calcitonin, capsaicin. Capsaicin we can see in some topical ointments, painkillers, and cannabinoids. And this is WHO pain relief ladder. It is a very important question for exams also. This is used for cancer pain. It consists of the ladder consists of 3 steps: 1, 2, 3. First of all, if it is we'll start with non-opioid. We may use or we may not use adjuvant. If the pain persisting or increasing, that is for mild to moderate pain, we'll use opioid. Only opioid, we may no need of adding non-opioid or adjuvant. And then the last step is opioid for moderate to severe pain. We'll use opioid with non-opioid or adjuvant. We will add one thing. So here you can see clearly WHO ladder pain in step 1. Non-opioid with or without adjuvant, and pain persisting or increasing. In step 2, we will add opioid with or without non-opioid or adjuvant. In step 3, opioid plus non-opioid plus adjuvant. And the proposed new fourth step is invasive treatments for improving the quality of life. The non-pharmacological measures, first one is the physical measures. Some of the physical measures for alleviating pain are exercises like graded exercise program that prevents joint stiffness, muscle atrophy, and contractures. And superficial eating modalities like hard packs, paraffin baths, fluid therapy, and radiation treatment. Ultrasound can also be tried for deep pain. Acupuncture, this is a Chinese form of medicine where we insert multiple needles at different points on the skin. It is useful mostly for chronic musculoskeletal disorders and headaches. And these points are needles are inserted at particular points on the skin. Those are known as meridians. And transcutaneous electrical nerve stimulation, it is widely used in chronic pain, also seen for to decrease the labor pains also. Some other physical measures are ice packs, chiropractic or osteopathic manipulations, massage, yoga, topical agents like menthol, salicylates, ice, local injections like steroid, lidocaine, and herbals and supplements. Glucosamine shown to be useful in osteoarthritis. Certain herbs like chamomile useful for colic pain. And homeopathies are flower essences for relaxation and visceral pain. And healing touch or Reiki using energy techniques useful with emotional components, and neuro-emotional techniques. And mind focusing therapies like meditation, yoga, guided imagery, hypnosis, and biofeedback, art, music, humor therapy, pet therapy. And distraction found to lower heart rate and respiratory rate and decrease pain up to 10 to 20%. Psychological methods are an integral part of multidisciplinary approach to pain management. Self-management techniques like cognitive methods, relaxation, biofeedback, operant techniques, and group therapy. And cognitive methods are based on assumptions that the patient's attitude towards pain can influence the perception of pain. Maladaptive attitudes contribute to suffering and disability, and patient is taught the skills for coping with pain either individually or in group therapy. Biofeedback. This provides biophysiological feedback to patient about some bodily process the patient is unaware of, like forehead muscle tension. And relaxation in the form of systemic relaxation of large muscle groups. Hypnosis is relaxation to suggestion plus distraction and alteration of the meaning of pain. Operant or behavior therapy based on premise that behavior in patients with chronic pain is determined by consequences of the behavior. Positive reinforcers aggravate the pain and negative reinforcers reduce the pain behavior. And coming to the invasive techniques, these invasive procedures are used only in severe intractable pain, but they will have intractable side effects. The intractable meaning is symptoms that persist despite carefully individualized patient management. And selection of the block depends on location of pain, its present mechanism, and the skills of the treating physician. These local anesthetics can be applied locally at peripheral nerves, somatic plexus, sympathetic ganglia, or narrow root centrally in the neuraxis, that is spinal or epidural injections. Somatic nerve, some of the somatic or peripheral nerve blocks are the trigeminal nerve blocks for trigeminal neuralia, cervical, thoracic, lumbar, parameter blocks, facet blocks for facet joints, pains, transsacral nerve blocks, etc. etc. Some images above your standards. Now, these are somatic block techniques. Sympathetic blocks are the blocking sympathetic ganglion which are inside the viscera, like stellate ganglion blocks, celiac plexus block, thoracic and lumbar sympathetic chain block. And epidural injections, like lumbar interlaminar epidural injections, fluoroscopic injections, transforaminal injections, and radiofrequency rhizotomy. Two fluoroscopic graded blocks, these are. And spinal injections. Therapeutic effects of the spinal injections are a combination of primary physiologic changes that result from the procedure and the secondary results arising from the enhanced pain control that allow other treatments. The spinal cord stimulation, also known as dorsal column stimulation, it produces analgesia by directly stimulating large J beta fibers in dorsal column of the spinal cord. And the mechanism is activation of descending modulating systems and inhibition of sympathetic outflow. The indications are sympathetically mediated pain, spinal cord lesions, phantom limb pain, and failed back surgery syndrome. The techniques are electrodes are placed epidurally and connected to external generator, and complications include infection, lead migration, and lead breakage. And there is one concept called intracerebral stimulation. In this, the deep brain stimulation is used for intractable cancer pain and rarely for intractable neuropathic pain of non-malignant organ. And electrodes are implanted stereotactically into periaqueductal and periventral gray areas for nociceptive pain. Complications are intracranial hemorrhage and infection. And coming to conclusion of the topic, so we know that pain is unnecessary and effective tools are available to help doctors evaluate pain in their patients. And unrelieved pain should be treated just like any other vital sign with aggressive measures. And effective therapies are available to treat the pain. Use guidelines to develop a rational plan to relieve the pain. Side effects are manageable. Anticipate side effects and treat aggressively. Addiction occurs very rarely. Trust your patient when they report pain. Tolerance and physical dependence can occur. Plan properly and you will succeed. Take the initiative and focus on relieving pain at your hospital. Your patient depends on it. These are the references.